Okay, well, good morning, everyone, and welcome to Tuesday Morning Grand Rounds. It's my pleasure this morning to introduce our speaker, Dr. Julie K. Furmick. She is the Director of Point of Care Ultrasound in our Pediatric Emergency Department here at Phoenix Children's. She's also a pediatric emergency attending, a clinical instructor of pediatrics at the University of Arizona, Phoenix. And somehow that just went away. Okay. She also she completed her pediatric emergency medicine fellowship at Carolina's Medical Center, Atrium Health, followed by a point of care ultrasound fellowship at Valleywise Health. She's board certified in both general pediatrics and pediatric emergency medicine, and serves as a clinical instructor at the University of Arizona College of Medicine in Phoenix. Her academic work focuses on POCUS education as well as POCUS program development for Phoenix Children's. And we were just discussing, she's actually to the point where the trainees now are potentially going to get more and more exposure to POCUS during your pediatric residency. She's presented nationally on point of care ultrasound, including prior inviter talks on pre-hospital ultrasound and pediatric POCUS applications. So Dr. Furmick, your podium is yours.
Thank you very much, John. I'm very excited to be here today. We have developed this program over the last 5 years after I finished ultrasound fellowship in 2022 and PEM fellowship in 2021. So I'm excited to talk to you guys about what we've done over the last couple of years and hopefully drum up some interest in POCUS. So I have no disclosures, just that we love POCUS. This is us scanning our various children. Most of them are Jaren's children here. I've scanned my kids a couple times. So lots of practice going on in our ED. Some of the objectives that I'd like to cover with you today is I want you guys to understand what POCUS is and how it can be used across a continuum of clinical situations. So this just isn't just an ED tool, but can be used in various different clinical situations. We'll also talk about how it can be used in time-sensitive diagnoses and ways that you can improve the clinical care of your patients. And then we'll review what goes into training, credentialing your attendings if this is something that you want to safely bring to your own department. This is my team here. Like I said, I started here in 2022 as the POCUS director. When I started, there was 2 dusty machines that sat in the back of our emergency department. And since that time, we've really expanded. We now have 4 brand new machines that are in our various emergency departments across PCH, and then we've also recruited. So Jaren Smith came back after fellowship and is now the director of POCUS education. And we recently have received protected time and hope to expand education, a formal education process to the residency department as well as different fellows. We're going to start today's presentation with a case. This is a case that was seen in our emergency department. This is a real case that presented. It's a 7-year-old healthy male, no past medical history. He presented to one of our outside satellite facilities with left-sided chest pain that had been going on for 5 days after he had been playing in a baseball tournament. No actual traumatic injury to the chest, but was pretty active over those 5 days, was complaining of intermittent chest pain, had some fatigue, headache, decreased appetite, some intermittent shortness of breath and intermittent fevers during that time. On physical exam, he was uncomfortable. He had reproducible anterior chest pain. Lungs were clear and heart exam was normal. The ED attendant got a chest x-ray that demonstrated widened cardiac silhouette and cardiomegaly. Again, this patient had no past medical history, and we are out at our satellite facility where we don't have echocardiogram readily available. So the ultrasound, point of care ultrasound was completed at the bedside by our ED attending. I'm just going to point out what some of these things are that you're looking at. This is the heart here. This is the pericardium. This all right here is fluid. So this is a pericardial effusion. Again, this is the heart in cross section. We call this a peristernal short access view. This is the heart here. This is the pericardium, and all this black here is fluid, so consistent with a pericardial effusion. So the POCUS exam allowed us to really direct care in this situation. So the diagnosis was made at bedside. Cardiology was able to be directly communicated with about our suspected diagnoses. We have a system in place now where our images seamlessly connect to the patient's chart and are available in packs. So we were able to have the cardiologist look at our images that were completed at the bedside. We were able to get the patient directly admitted to the cardiology floor here at the main campus, and an echo tech was available and ready. This was in the middle of the night, so they had to be called in, but they were ready upon arrival of the patient. So again, improving the time for clinical care on this patient. Once at Phoenix Children's Main, a formal echo was done that confirmed a large pericardial effusion with no tamponade, thankfully. They tried to treat him medically for a short period of time, but unfortunately that did not work, and he was taken to the OR and had a pericardiocentesis done. 170 cc's were removed from this patient, and he was diagnosed with viral pericarditis with a large effusion, treated with colchicine and discharged home. He did test positive for rhinovirus. So what is POCUS? What it is it's a real-time ultrasound that's completed and interpreted by the provider at the bedside. So these scans are completed by you as the doctor or the PA, whoever's taking care of this patient, and then also interpreted in real time. These images don't go to radiology for the radiologist to interpret. This is something that you're doing at the bedside in real time with the goal of answering a very focused binary question. So is there a heartbeat? If you're doing CPR on a patient, and we unfortunately have to do this a lot in the ED. So before we call a time of death, we like to actually look at the heart. There is some evidence that feeling a pulse isn't as accurate as we once thought it was. So taking a probe and looking at the patient's heart and making sure there is no life sustaining heartbeat is really important for the patient. Is there a foreign body? A lot of times, parents come in and they're like, this kid stepped on a cactus thorn. Is there something still in there? Ultrasound's really great at identifying foreign bodies. Is there a fluid in the bladder? This is the bladder right here, this big fluid collection. So before cathing a patient, a lot of parents don't want their baby cathed at all, right? Let alone 2 or 3 times when you're not able to get urine on the first time. So making sure that there's actually fluid in the bladder in a patient who's dehydrated prior to cathing them is helpful. And is there a pneumothorax? And we'll kind of go over all of these different applications later, but it would be helpful to know if there's actually a pneumothorax in a patient who might be in tension physiology in front of you before you stick a needle in to do a needle decompression. This slide just really illustrates that the technology has evolved pretty significantly over the last 50, 60, 70 years. Ultrasound started, it was adapted from the sonar that we used to pick up submarines in the war. And that same technology was used initially in the 1940s. This was the first ultrasound where they submerged the entire patient in a bath of water and then used sonar waves to see their internal organs. That obviously is not super easy to do. So over the last couple of years, we have seen this really progression to a handheld technology where now you're able to plug in a probe to your iPhone. And in our clinical situation, we're very fortunate here at PCH where we have a ton of resources. So might not be as needed to connect it to your cell phone, but you can see in different situations where maybe you're working across the world in underserved locations where they might not have a radiologist, they might not have internet to send images to someone else, they might not have a large POCUS machine that they can do. Having something handheld can really improve care across a continuum of situations. So again, what is POCUS? I just want to reiterate that this is an operator performed and interpreted ultrasound at the bedside. It's goal directed, It's immediate assessment of the patient. These are patients that most of the time are hemodynamically unstable, or you're using ultrasound to ask and answer a clinical question that's going to change their clinical management in that exact moment. You're asking binary questions. In most cases, this is considered standard of care. There is some situations where, for ultrasound guided lines, central lines, ART lines, this is considered standard of care. And it's increasingly available, as we went over. You also need to know what POCUS is not. So this is not a replacement for formal radiology. This is not echocardiogram. We both have very different roles and very different questions that we're asking. This is not a comprehensive study. Like I had mentioned, we're looking, is there a heartbeat? Is there an effusion? Asking very specific questions. There's actually some studies that show that as your POCUS program grows, your radiology department also flourishes as well, because we end up finding things that we maybe wouldn't have found and sending people for formal ultrasounds. And it's not only an ED and ICU tool. So that's my goal here today, is to be able to show you that really this can benefit patients in all clinical scenarios. Back to our patient here that we talked about a little bit earlier, and why and how POCUS changed everything. You can see how a patient, after 5 days of exercise playing baseball, you might easily diagnose this patient with costochondritis or musculoskeletal chest pain, and he could have been sent home, but POCUS asked and answered the right question in real time. Is there a pericardial effusion? And we were able to really streamline the care in this patient. And this is just one example. We have many more examples of patients that have been, their care has been improved by POCUS. It's not a subspecialty tool, it's a patient care tool, and I hope to demonstrate that to you today. So why is our pediatric population ideal for POCUS? Well, there's no ionizing radiation that we see with POCUS. You guys know this, right? That ultrasound, every CT that is saved for a patient is a meaningful win for that child. With the ALARA principle, cumulative lifetime radiation exposure is what matters most to our particular patient population. So if we can save them a CT, obviously we want to do so. Kids also are usually smaller and thinner than adults. They usually don't have a ton of comorbidities. They haven't been smoking for 50 years, right? So they usually have thinner chest walls, less, body habitus, and we're able to get superior acoustic windows and usually see a lot more anatomy and pathology on these patients. And young patients often can't localize where their pain is. So we're able to get information on what could be going on with these patients with very little downside. Like I said, there's no radiation to this, usually doesn't cause a ton of pain and discomfort. So as the clinicians can usually help out quite a bit and give us some diagnostic insight into what's going on with your patient. It can also avoid sedation. There's been multiple cases in our ED where we've been able to avoid sedation altogether for forearm fractures in patients that can tolerate nerve blocks. Same thing with femur fracture reductions and splinting. We're able to do a nerve block and avoid sedation in these patients altogether. Decreases procedural anxiety, decreases attempts. So IV access in patients that are difficult to obtain IV access, decreasing the attempts in these patients, and also improves patient and family experience, right? The parents respond positively to having real-time information at the bedside. So we're going to go over evidence here, and I apologize, I'm going to be reading from some papers. I just don't want to misquote any of these papers here. So we're going to go over the evidence behind POCUS, first outlining how POCUS improves time to diagnosis. So these two particular papers talk about time to pericardiocentesis in the setting of pericardial effusion and tamponade, but there is similar evidence supporting the diagnosis of pneumothorax and intussusception. So in this first study here, this was a prospective randomized controlled trial in which 73 patients were evaluated, and the POCUS arm had decreased time to pericardiocentesis 11 hours versus roughly 70 hours in those who needed formal echocardiogram, and overall shorter length of stay too. The second study found similar findings. This was a retrospective chart review, and those patients who did receive POCUS had a decreased time to diagnosis, about 6 hours versus greater than 12 hours in those who needed formal echocardiogram. And then it also talked about time to pericardiocentesis was roughly cut in half to 28 hours versus 48 hours. And I tried to put some QR codes up here if you guys want to pull up these articles to read for yourself, but that's kind of just going to be going over the summary. So this is talking about CT utilization. As I mentioned before, if we can decrease the amount of CTs that we're doing on our patients, that's a win. So this first study talks about the use for soft tissue abscesses and cellulitis. This one here was a prospective observational study in which after being able to introduce a curriculum in which they taught their attendings how to use POCUS, they were able to decrease length of stay and lower cost for their patients and decrease CT utilization. In the second study here, this talked about suspected appendicitis. And this was in a particular place where they didn't have ultrasound available like we do with radiology, who's readily able to do ultrasounds on appendicitis. This particular one, after introducing a POCUS program and curriculum, they were able to decrease their baseline CT rate from 44% to 27%. And there were no cases of missed appendicitis. We're going to talk about diagnostic accuracy of our patients receiving POCUS. This first one here was a systemic review meta-analysis in which they reviewed 14 studies and showed that point-of-care ultrasound has good diagnostic accuracy in differentiating abscess versus cellulitis and led to a correct change in management in roughly 10% of cases. This second study here, I don't know if you guys can see, but you might recognize a couple of these authors here, but demonstrated that bedside ultrasound can be used pretty accurately in the diagnosis of clavicular fractures. And this might change management. For example, if you're an outpatient provider working in an office, there's not much we do for clavicular fractures when they're small and non-displaced. We put them in a sling, right, and send them to follow up with ortho. So if you're able to diagnose this in your clinic, you know, you might save the patient a trip to the ER to get an X-ray altogether. So it definitely can change management depending on where you're working. And in this particular situation, they were able to diagnose clavicular fractures with a pretty high sensitivity and specificity in the high 89 to 90% range, did not increase pain scores significantly, and overall decreased the amount of time it took to get the diagnosis to the patient by decreasing the time that it took to get to ultrasound, 76 minutes versus radiograph at 107 minutes. Procedural safety, I think this kind of, most of you probably know that an ultrasound guided line decreases the risk to your patient. This first one talks, though, about how ultrasound can be used for lumbar punctures in patients. In this particular one, overall first-time attempt in POCUS-assisted lumbar puncture was successful in 72% of patients versus 59% of patients in the standardized group. The second one talks about central venous catheters and how they were able to ultrasound-guided insertion significantly increase success rate by about 30%. And lastly, patient satisfaction. So this talks here about how we are able to patient experience. They evaluated patient experience in a POCUS group, and POCUS families said or reported on surveys that they had significantly greater perceived importance of their imaging, which makes sense, right? You're at the bedside, you're doing this, you're walking through the family through it as you're actually completing these ultrasounds. And they feel like it directly alleviated their stress and anxiety. And in the second one, it talks more about length of stay, but in this patient population who received point-of-care ultrasound, they had a shorter length of stay compared to radiology performed ultrasounds. So let's talk about how POCUS can be applied in different clinical situations. We're going to first highlight how it's currently being used. So this image up here is one of our fellows in the sports medicine clinic using ultrasound. They use ultrasound quite regularly there for those who have rotated through that department. This is our critical care transport team. We staged this photo for this presentation. This is Amanda. She's one of our amazing nurses that works on our critical care transport team. And they have ultrasound available to be able to start lines on these patients. This is Jaren's daughter. I had her come in and we staged this photo. But this is how they use ultrasound in our critical care transport team. This is our team here on one of our ultrasound days. For our fellows, we have a longitudinal curriculum in which they receive hands-on POCUS education every other month. We alternate with sim for them. So 1 month they get sim, the next month they get ultrasound, and we scan each other and work on determining normal anatomy versus abnormal. This is a photo that I created on AI actually, but the main thing I want to demonstrate here is that ultrasound is being used regularly in our anesthesia department to provide pain control with nerve blocks to our patient. This fake guy here is completing a fascia iliaca block on someone. And then this is Jay Radikar in our PICU now, working with one of the fellows identifying cardiac physiology on one of our patients. So if you're in the office setting, how can you use POCUS? How can you bring this to your patient? So this is an ultrasound of what an abscess looks like in real time being drained. So you guys know that the treatment for abscess is drainage. So if you're able to do an ultrasound in the office and say, hey, no, this is just cellulitis. This is what cellulitis looks like. It's kind of cobblestoning across the soft tissue. There's no drainable fluid collection. Then that management changes, right? You can start the patient on antibiotics and you can discharge that patient home, versus if you do an ultrasound and you see a large fluid collection, you may or may not be able to drain that in the office. And then that patient, should probably come to the ED if that's your situation. So can definitely change management. This here is a soft tissue ultrasound where a foreign body is identified. So, most foreign bodies are not emergencies. So again, if you saw this in the office, you did an ultrasound, you saw a foreign body, you could easily start that patient on antibiotics and have them follow up in the surgery clinic, again, saving them a trip to the emergency department if not needed. This is another picture of a large foreign body here in the sole of a foot. You can see that right there. This is pneumonia. So this is this is the lung here. This is the diaphragm. This is the spine. It's what we call a spine sign that's seen in the setting of a clinical pneumonia. You see these little movements across the screen down here. And that's what we call a dynamic air bronchogram. It's incredibly specific for pneumonia. So this might be a clinical situation where, you have a patient who you can't really tell if it's bronchiolitis or pneumonia based on how they're presenting, and you do this. Well, this is a very specific finding for pneumonia. You could start that patient on antibiotics. And hopefully if their respiratory distress is not too severe, really streamline their treatment. And then we kind of talked about this earlier. This is a bladder ultrasound. So if you're able to cath in your urgent care or your primary care setting, making sure that there's urine in the bladder is probably going to alleviate a lot of stress for the parents. These are some other examples. These are all MSK injuries. This is what a fracture looks like. So this is all muscle at the top. This right here, this hyperechoic line is the bone. This is a non-displaced radial fracture. You can see at the end, it kind of points to it. That's a fracture there. Again, nothing that would need reduction, something that could be splinted and followed up outpatient. This right here is a clavicular fracture, a non-displaced clavicular fracture. So again, soft tissue up here. Bone is this hyperechoic stripe here with this break in the cortical area right here that demonstrates that fracture. This is an intramuscular hematoma. So this is a large fluid collection there that may or may not draining depending on the clinical situation. This is a hip effusion. We have kids all the time who come in with, minor trauma, maybe no trauma at all, and they're limping, not walking. So hip effusions are very easily diagnosed on point of care ultrasound. And this here, hopefully you don't see this in your clinic, but this is a intramuscular rupture. So all this here is soft tissue, and you can see all this is a rupture of the actual muscle there. We'll talk about how it's being used clinically in our EMS situations. So this here is a pneumothorax. So the way ultrasound picks up pneumothorax is when we breathe, the visceral and parietal pleura rub on each other, and that creates movement. And the ultrasound is able to pick up that motion and movement. And in a normal, healthy patient, I don't know if I have a normal one a little bit later, but you can see kind of this coming in and out of view right here on the left side of the screen here, or the right side, I guess, if you're looking from the audience. That is the lung that's coming in and out of the field view there. And this is what we call a lung point sign. So that pneumothorax is going up until this actual point. And you can see on the other side of the screen, there's no movement. And that's because there's air in between the visceral and parietal pleura. So as the patient takes a breath, there's no movement there. And that's very incredibly specific for pneumothorax. So if you're in a pre-hospital setting and you're 45 minutes away and your patient's decompensating clinically, and you saw this, a needle decompression would be indicated and probably give you a lot more security in that diagnosis. This is actually the image of someone being intubated. So this is the trachea here. We can use ultrasound in real time to make sure that the patient is not intubated in the esophagus. So here is the trachea here. And as you can kind of see coming in and out of view is this what we call a double barrel sign. So you have one and then another one comes up right here, and that's the tube passing through the trachea. And ultrasound is helpful in this situation because, again, you don't need a radiologist to tell you this. This is as your patient is decompensating in front of you, you're in the middle of a field trying to get this patient to the closest hospital. You can intubate them and make sure that you've done so properly without an X-ray. This is a fast exam, so we'll go over this a little bit later on what this is, but essentially this is an exam that's used in the setting of blunt abdominal trauma. And if you, as an EMS provider, the way that this works is when you're called to the scene, you as the EMS provider or paramedic are part of your responsibility is to determine the close and most appropriate place to bring this patient. So you're not always told by a physician where this patient is supposed to go. You have to make that decision. So if you have a patient who's in a traumatic accident and your decision is, should I take them 20 minutes up the street to the, community hospital or 45 minutes up the street to the trauma center, if you're able to identify, hey, this patient's hemodynamically stable and they have free fluid in the abdomen, that is a traumatic injury and until proven otherwise. And really the most appropriate place to take that patient would be the trauma center. This is an ultrasound here that demonstrates a catheter placed in a central vein here. So as I showed you that picture earlier of Amanda completing that central line, that IV. This is another example of how it can be used in the EMS situation. All right, so I want to just go over a little bit of data here. So this one talks about future applications of POCUS and specifically on how to use it. For lung sign, we talked about lung sliding can be used in real time to determine if your patient has a pneumothorax and whether you should be doing a ultrasound. This one here in lung sliding was a randomized blinded study in which they took cadaveric specimens, intubated them, and then saw how well after a training situation their paramedics were able to correctly identify lung sliding on ultrasound. And they were able to do pretty well with a sensitivity of 96 and a specificity of 93%. And then the first one here, it talks about pre-hospital fast. So this one was performed on 202 patients, either by a physician or paramedic. There are some physician riders across the country that sometimes go on EMS. And in this study, they were able to correctly identify free fluid in the abdomen of several patients and altered the location in which these patients went in upwards of 22% of cases. So we're going to talk about the emergency department now. This is where it all started, right? This is the holy grail of POCUS. In the 1990s, this started just like almost everything in medicine, started in the adult population and the adult ED. And by 1994, the first EM ultrasound curriculum for our adult colleagues was developed. And by 2001, ACGME had added it to a core requirement for our adult colleagues. By 2008, it was kind of noticed that, hey, this is really lacking for our PEM department in general. And then by 2010, the first PEM POCUS fellowship was started. By 2014, the P2 network was completed. If you're interested in POCUS, that's a great place to start. It's a network that's really talks about how POCUS can be done and across the country creates standards for us for the PEM department and how we use POCUS. And between 2019 and 2022 is when the curriculum has now become part of our fellowship training and core applications that we're expected to teach our fellows. But this is a great example of how recently this has really, become a thing. In 2019 is when this started to become expected for our PEM fellows. So it's not that long ago, and we have lots of work still to do. So we're going to talk about EFAST. I kind of talked about this earlier, but EFAST or FAST stands for Focused Assessment, Sonography, and Trauma. And essentially what we're looking at here is a non-invasive bedside ultrasound protocol that is indicated in hemodynamically unstable patients who have had a history of blunt abdominal trauma. And in this situation, we are looking to see our binary question that we're asking is there free fluid around the heart? Is the E portion is extended? Is there a tension pneumothorax, or is there free fluid in the abdomen? And you can see here, this is the liver, this is the kidney, this is the diaphragm, and this is free fluid here in your patient who is hemodynamically unstable and has had a significant trauma, right? So that's extremely concerning. Here we look at 4 different locations. This is the left upper quadrant. This is your diaphragm. This is your spleen. This hypoechoic area here. Hypoechoic means dark. That's fluid collected right there. Ultrasound doesn't have the ability to tell the difference between different types of fluid like a CT does, but based on your clinical scenario, this would be blood until proven. Here is the bladder. We look in the bladder area as well. You can see this is free fluid down here, just to the lateral aspect of the bladder. And this is the heart. So we kind of, I showed you that picture earlier, but this particular patient is in pericardial tamponade. And you can see this is the pericardium. This is the heart here, and this is fluid. This is what a pneumothorax, this is normal lung here. You can see the motion that kind of you talk about, this is a normal patient. So as that patient takes a breath, then there's a visceral and parietal pleura movement, and you can see the ants, what we call ants marching on a line, and we expect that movement as the patient takes a breath. So if you don't see that, you don't see any movement, then you get concerned for pneumothorax. These are the guidelines, the Western trauma guidelines. The main thing I want to highlight here is that this is indicated for a very specific patient population, okay? Like I had mentioned, this is not a comprehensive organ study. This isn't looking to see exactly which organ is ruptured or where the injury is, but it's indicated in hemodynamically unstable patients with blunt abdominal trauma. So it's saying, there's no obvious extravasation. Your patient is not stable. They are unstable. Do they have a positive FAST? Yes. Are we able to stabilize them? Can we get them to CT so we can get surgeons more information? And, can we give them a transfusion? Can we do some resuscitation? If not, then we consider OR versus going straight to the OR versus IR. So knowing your indications for your exam is just as important as knowing how to do it and what you do with your positive findings. This here is the data behind pediatric FAST exams. So The main thing I want to highlight here is how low your sensitivity is. So in this particular study, this was a systemic review and meta-analysis that reviewed 18 studies, over 2,000 pediatric patients. And the gold standard here was, unfortunately, either autopsy, CT, laparotomy. And that was the gold standard in this situation. And they essentially, across these studies, the specificity was very high. So if it's positive, it's very helpful. But the sensitivity in these studies ranged anywhere from 20 to 80% with a pooled sensitivity of 35%. So if negative, not super helpful for our patients. The sensitivity tends to be a lot higher in the adult population. Cardiac. So we talked about how it can be used in trauma. Let's talk about how it can be used in cardiac. We kind of talked about it with our case that we presented earlier, but our binary questions that we're asking here with cardiac is, if you have a patient in front of you who's hemodynamically unstable, you're going to take the ultrasound and look, how is their cardiac function, right? Are they hemodynamically unstable because their heart is not beating or because they're hypovolemic, right? Do I need to give them more fluids or less fluids? That's my question in the emergency department. I often know very little about the patient that's in front of me. And especially if they're in a resus bay and they're unstable, I have very little time to go through their chart. And my question is, I can take an ultrasound and I can put it on their heart and I can say, okay, grossly, I have normal cardiac function. I have a very small IVC. I can give this patient more fluid. This patient needs a lot more fluid. We had a patient just last week where we did this. He did have a cardiac history, but given how sick he was, we didn't really know much of it at the time when we were resuscitating him. We put the probe on. We were able to see a very large plethoric IVC. And after a 10 cc kilo bolus, we put him straight on pressors versus doing a full 60 per kilo resuscitation in that patient. Our other question is, is there pericardial effusion or tamponade? We talked about this in the case earlier. And then cardiac arrest, is there a heartbeat before we call time of death on these patients? Here's some pictures of, this is what a normal cardiac ultrasound looks like. So this here is your right ventricle, left ventricular outflow tract. This is your mitral valve. In a patient who has normal cardiac function, this mitral valve grossly should come up and hit the interventricular septum, because we also don't have a ton of time to do a ton of measurements. I'm not doing math or measurements here in the emergency department. I'm grossly looking at function to say, how can I resuscitate this patient? This is an example of a heart that's not beating well, right? So you can see this is a very different cardiac exam, and you can see this is barely kind of fluttering here, this mitral valve. This is the heart in cross section. So this is what we call our peristernal short view. So what you're doing is you're taking off the atria, you're looking down into the heart, almost like it's a bowl past the mitral valve. These are the papillary muscles of your left ventricle, and you're looking for a nice concentric squeeze of that heart. This is an example of one that is not doing so hot. So pretty obvious, right? This paper here was actually a really interesting paper. So they said, how good are ER doctors at kind of grossly estimating left ventricular function in these patients? Because like I said, I don't have a ton of time to be doing math at the bedside and calculating ejection fraction. That's not what we're doing. It actually shows that we're pretty good at it. The more ultrasounds that you do, we had pretty significant overlap on determining normal versus abnormal in our patient. And that's our main question, right? I mean, they're going to get a formal echo. These are all patients that are very sick, but sometimes it takes time to arrange a formal echo. So in that situation, we want to know, is this normal, reduced, or severely reduced function by visual estimation? And we actually overlapped pretty significantly, and we're very good at it. This is how it can be used in the lungs. So pneumothorax, it's great at identifying, we've been over this a couple times now, it's great at identifying pneumothorax, pleural effusion, pneumonia, interstitial edema, pulmonary edema, intubation. So this is a normal lung. We talked about this. This is the visceral parietal pleura. As it moves, it kind of creates this ants marching on a line movement. This is one that's not moving. So this is a pneumothorax. You can see how there's absolutely no movement. This is a rib. This is a rib. This is the pleura here. No movement. So this would be concerning. Now, this has to be taken in the clinical situation of your patient. So anything that does not inflate that lung is not going to cause movement. So if your patient is maybe right main stemmed because you intubated them too deeply, you're not going to inflate that lung. So keeping that in the clinical context and, it's probably poor form to do a needle decompression on somebody that you just main stemmed, right? So making sure that the clinical situation and what you do with a positive finding is just as important as knowing how to do the scan. This is an example of interstitial edema or pulmonary edema. So you can see these kind of like shadowing coming down. So these dark shadows are the ribs. This right here is the connective tissue here. And then you can see these kind of like shadowing that's coming down that's like bright. That's what we call B lines. And it almost looks like a flashlight. That's how I like to think of it, the flashlight coming down from your pleura. And that is what's seen in the setting of pulmonary edema. So if you saw this in a patient who's maybe in heart failure or you're suspecting heart failure, this would be concerning for pulmonary overload. See if I have any other pictures. Yeah, this is what we talked about earlier with our air bronchograms. This is a dynamic air bronchogram. This is very specific for pneumonia. This is also a specific sign for pneumonia. This is what we call a shred sign. You can kind of see it looks like almost shredded on the side here. This is ribs, the pleura here, along where that connective tissue is kind of shredded there. And that's very specific for pneumonia as well. That's all the... Oh, this is an interesting picture too. This is a large effusion. This is the lung kind of just floating in lots of fluid. That shouldn't be the case, right? You have your liver here, you have your diaphragm here, and then fluid all here with your lung just kind of floating in a big bath of fluid. This is unfortunately a situation we wish we didn't see as much as we do in our ED, but transabdominal pregnancy in adolescent patient, again, our binary question is there a baby, and does said baby have a heartbeat? And can we get them somewhere that takes care of pregnant patients? So our main question here, we actually have a lot of pregnant people who also come here, like adults. They see Children's Hospital, they're pregnant with a child, they show up in the ED. We have to tell them we don't deliver babies here. But doing an ultrasound on that patient often gives these moms a lot of peace of mind when they're really worried that their baby is not okay. So you can do a quick ultrasound at the bedside. Yes, your baby's heart is beating. Let's get you to a place that can more appropriately care for you. And then also talking about ectopic pregnancies. So in a patient who has a positive pregnancy test and is hemodynamically unstable and has a positive FAST exam, that is a ruptured atopic until proven otherwise. And that patient would be indicated to go straight to the OR with our gynecology team. This here is a positive FAST exam, kind of what we went over. This is the liver here. This is the kidney. Again, this is all free fluid. So this would be extremely concerning in that patient for a ruptured ectopic. We're going to talk about procedures and airway. So vascular access, that goes without saying. You guys, most of you know that IV access is done and can be done with ultrasound. Bladder scans, we kind of talked about that as well. Procedural guidance, abscess identification, arthrocentesis, nerve blocks. We regularly do arthrocentesis in the ED and under ultrasound guidance. Ocular, this is really becoming quite popular and quite needed in the ED. This is a retinal hemorrhage here. You can see that at the back of, there should not be anything floating in the back of the eye. A normal, I know I didn't put a normal up here, but a normal eyeball is just black. There's nothing floating in the back of the eye. This is all abnormal here. This is what a globe rupture looks like. Globe rupture, if you actually seriously suspect globe rupture, ultrasound is contraindicated. So you shouldn't be doing an ultrasound on these patients. These images were all taken off a directory that's free online if you ever want to go on. This is called the POCUS Atlas. They have pictures of all normal anatomy. They colorize their anatomy too. So if you're not sure what you're looking at, they'll have normal on there and colorize and label what they are. And then they have positive pictures too. And it's all these providers, ultrasound providers across the country upload their de-identified images up here to share. So these are all where I got these images for. This is a picture of a lens subluxation here. You can see, again, she has nothing I don't know, has nothing floating in the back of the eye, but you can see this is the lens, should not be moving around like that. Doing okay on time? Yeah. Okay. So I want to kind of just go over a case here that I actually saw at our Arrowhead emergency department. Is a 21-year-old female, past medical history of trisomy 21, who was managed by ophthalmology here. She had a history of glaucoma, and multiple eye surgeries in the past, and she was presenting for acute worsening and right-sided eye pain and redness. Otherwise, review assistance and vital signs were normal. And this was what her ultrasound looked like. So this is what endophthalmitis looks like, all infection and pus and abscess floating around in the back of her eye. We were able to, again, these images were directly uploaded to the patient's chart. The ophthalmologist was allowed and able to look at them in real time from the main emergency department. We transferred her ED to ED. Ophthalmology took the patient to the OR for intravitreal antibiotics, and she was discharged from the PACU. So, all right, a lot of this starts to come a little bit redundant because a lot of these applications can be used in different clinical situations, but we'll go over what you can use in the NICU and the PICU. It's often used for pulmonary, effusion surveillance, pneumothorax, cardiac, hemodynamic monitoring, IVC. If your IVC is very large or very small, that corresponds to how much more fluid resuscitation this patient might need. And then obviously central line placements. There's also, I didn't put it on here, but there's been some recent evidence that it can be used for identifying the placement for UVC catheters, can also be used for necrotizing enterocolitis. Now, again, we practice in a very luckily resource-rich environment, so we could easily send that patient or have ultrasound come up and do a formal ultrasound on a patient that you suspect neck in. But if you're not as fortunate, there is some evidence that bedside ultrasound can be used to identify neck in your patient. Perioperative, again, regional anesthesia, nerve blocks. Our team routinely uses ultrasound for these applications. And then inpatient wards, I talked to Tim Raghib about kind of some of the things that he anticipates, because my goal is to grow this program throughout the hospital and the institution. So volume status, fusion monitoring, access, lumbar punctures. There's multiple times where these babies come to us and they are just so dry that even when we try to do a lumbar puncture, we can't get any fluid because we just haven't had enough time to resuscitate them, and antibiotics are of the essence, right? So we get a line and we try to do the LP and, we give them as much fluids as we can, but sometimes we have to send them up after an unsuccessful LP. So, if you guys are able to do lumbar punctures with ultrasound, increasing your success rate after, unfortunately, we've tapped them a couple of times, it makes it all that more difficult for you guys. Training and credentialing. So the main point of this slide is I want to say I've already done all this, so don't reinvent the wheel. Okay. I started in 2022 as the POCUS director. You usually want to start by defining the scope for your department because your applications, if you're in the NICU, your applications are going to be a lot different than my applications in the ED, right? So working with your department, we've already developed very standardized DOPs in our emergency department. So if POCUS is something that you're interested in bringing to your department, I'd like to help you do that safely. And make sure that we get your faculty and your fellows and your residents trained appropriately. So you can see there's a lot that goes into a program. You have to be able to provide ongoing CME. You have to make sure that your providers know how to do them and not only know how to do them once, but can do them continuously, how you can document them, integrate them into your EMR so that there is no medical legal, backlash if you don't have these, if it does change clinical outcome and you don't have them documented in the patient's chart. Patient callback, right? Like if you do have a QA process and, if Jaren finds something in my scan that I missed, for example, do you have a process in place on calling that patient back and making sure that they're taken care of appropriately? And then how do you bill for it? We've already set all this up in the emergency department. So please let us help you. And this essentially is just saying, save time, save energy, don't reinvent the wheel. We're here to help you with this. So again, just in summary, this is not a subspecialty tool. This is a patient care tool. We would love to talk to you about how to bring this to your department safely. And if it's something that you're interested in, reach out to Jaren or I, and we can get that started. That's all I got. Yeah. Anybody, should I go back to the?
Okay, here's our survey thing, and then I'm gonna turn on the overhead mics. Okay. So now you can take questions and people can hear us.
Yeah. I was just curious in terms of, you know, with the resources like the POCUS Atlas and stuff like that, is there an effort to make with ultrasound, maybe not POCUS itself, but like sort of dynamic things where with like the use of, if it's artificial intelligence or whatever, to like label different things? If you say like, I'm doing a fast exam and it can like label like free fluid or things. I didn't know if, I was curious if there's an effort for that.
Yeah. So the question is, for those that are home, is there any role for labeling and using AI as you do ultrasounds to kind of highlight different things that you're looking for? And the answer is yes. There's actually, and if you're interested, we are having a vendor come out called SonoSim. There's lots of different ones. And I have no stock in this company, but there are companies that are now using AI to train because there's only so many of us, right, to train at the bedside with you. But they have models where you can train using models and it will pull up the picture of what it should look like. They have actual full simulator models where they have them at the U of A, where we will scan over the right upper quadrant, the left upper quadrant, and it will show you a positive free picture, you know, and we can actually use that to train patients and train our faculty. And we can put on the screen what a positive might look like, even though it's a negative scan when you're actually scanning. There's also the technology, depending on how much you want to spend on your ultrasound machine, that will identify the artery, that will identify the nerve for you, that will do smart identification of free fluid for you while you're scanning your patient. Obviously, that technology is very expensive, but there is technology that is available for identifying those things.
The PCP like outpatient setting, I know some people have like the portable like ones that you buy, they're like a couple thousand, like they're fairly inexpensive compared to the ones that we have here. Is that also things that you would represent as like a reliable tool?
Yeah. So the question was, is using handheld devices reliable? So the question is yes. I don't think, the answer is yes. I don't think there's any the actual technology behind these handheld devices is very good. Where the gray zone gets into is the medical legal standpoint of that, right? They are not always connected to your patient's chart. So if you're going to be using them for medical decision making, that's where it gets a little tricky, right? If you're going to document in your chart that I did a bedside ultrasound on this patient and then you can't store that in that patient's chart. You can't store that anywhere. There's no way for anyone to verify what you found, what you didn't find. There's no way to QA that. There's no way for anyone to check your work. And God forbid something happens to that patient, there's very little recourse on your side to say, hey, this is what I saw. So that's where it gets a little tricky. So that's why I'm here today. I really want to help you bring this to all the departments, but I want to do it in a way that protects us as providers so that it's done in a safe fashion and also protects our patients too, right? If something is found, that we're able to get them to the right spot. So I want it to be used appropriately. Yeah.
Maybe a sort of silly question, but at what point I'd like this idea of binary question to me that like really kind of focuses this. At what point do you have so many binary questions that it becomes like a diagnostic study, right? Like, so if this kid, the 7-year-old, didn't have a pericardial effusion, would you then look for a pneumothorax if that was negative? Like, where do you say, okay, we need to sort of like start at the beginning and go down this more traditional path, for lack of a better term, to work that kid up?
Yeah. So I think that the question was at what, the binary question, at what point do you kind of go down a more traditional path? And I think the point is in the ED, we want to make sure that our patient is safe. So once you're able to kind of safely say, hey, there's no absolute emergency right here, we still need to figure out what the cause of this patient's chest pain is. But with our binary question, we are asking very specific questions of, is this patient safe? Do they have a pneumothorax? Do they have, anything that I need to treat emergently? So I think once you kind of rule out those safety factors, and a pneumothorax needs to be dealt with emergently, right? A pericardial effusion needs to be dealt with in an emergent fashion. When you have done those things, then I think re-looking at your patient and starting from square one and maybe sending them, we do this all the time. We'll do the ultrasound and we'll be like, hey, everything of your heart looks okay today, but this is not a comprehensive exam. We want to send you to cardiology. Here's a referral to cardiology. They'll see you. Our main question is, can they wait 2 or 3 days to see cardiology in the clinic, right? Can I send them home, or do I need to send them to the main campus to get an echo in real time, right? So that's kind of our main question.
Here's one that came in through Zoom. It says, do you need to do a fellowship in ultrasound to charge professional fees?
No, absolutely not. You just need to be credentialed, okay? And we are working to get our attendings in the emergency department credentialed. And that kind of goes back to that outline that I showed you guys. But you first create a DOP that outlines how you can train these attendings and what your minimum standard is. And everyone's a little bit different, right? The American College of Emergency Physicians put out guidelines on what they think is the minimum standard for training their attendings, and it's 150 scans. Right here, we don't do that. We do about 50 scans. And at that point, I feel comfortable enough to say, hey, enough of what you're looking at that you can complete and bill for these. So no, you do not need to do a fellowship, but you do need to do some training, and you can get training in various different ways, right? We are in the process of setting up CME for our attendings in the ED, where Jared and I will be completing actual bedside teaching and seminars. And if there's enough interest across the institution, we can expand that outside of the emergency department where we train other attendings and stuff. And the goal is just to make sure that you're doing this safely. And there is most of these like professional conferences, the AAP, ASEP, they all have little seminars on focus as well. So easily to get it, training outside of PCH as well.
Okay, then there's the second part of this question. Also, are there documentation requirements regarding what you scanned in order to charge for focus, and where are images stored? And I don't know where this doctor's from, so
yes.
Maybe they were outpatient or something.
Yeah, so I can just speak to what we do here at PCH, but there are different ways. So yes, the first thing is you have to be able to bill for it, you have to store the image in the patient's chart, and you have to document. There's different ways to do that. Very large POCUS programs, where I did my POCUS fellowship at Valleywise, for example, they had a middleware software called QPath, and Butterfly has something similar where the image goes into that kind of middleware software. You have a QA process where the image I complete, for example, goes in there. Someone else looks at it to make sure I didn't miss anything. And then I put in what I think the interpretation is. And then subsequently that QA person, whoever is overlooking the scan, looks at it and makes sure I didn't miss anything, looks at my interpretation. And then that goes to the billers and coders and say, hey, these are billed like with CPT codes. So these are billed like procedures. So just like any other procedure, there has to be documentation that you did it. The way we do it here at PCH, we don't have a middleware software. So that image connects our machines, connect directly to PACS. So the patient pops up on our work list. We're able to select the patient. It's connected by birthday, MRN, just like any other image that you do a chest x-ray. You do the image, and then that image goes directly to PACS. It is not a PACS that's connected to radiology. So again, this is not radiology interpreting these scans. Then we put in a procedure note, just like we do with any other procedure. So on the way we have done it in the ED is we've created a template in our procedure note template. So for those that have rotated through the ED, you pull up the procedure note template and there's an area that says lumbar puncture or abscess or laceration. Well, at the very bottom, it says POCUS, and you click on POCUS and you document what you're finding. And then all of that comes to Jaren and I, and we QA that and we give our attendings real-time feedback, whether it's in person or via email. Then once that's done, it's documented, it goes to the billers and coders and they bill appropriately for it. Yes.
With the sensitivity of POCUS being largely user dependent, is there a standard amount of training that people should be required or any exams that they can be taking to ensure that they're appropriately using POCUS?
Yeah. So the question is there a standard for training these providers on using POCUS? And I think that depends on your application and where you're at. So I can speak from the emergency department. We use all the guidelines from ACEP, so the American College of Emergency Physicians. They, as I showed you in this talk, the adult ED providers have been doing this for a very long time. So when I created my DOP for the pediatric emergency department, I used them as a reference point and how much should I be training these attendings. The NICU, for example, has been doing ultrasound for a very long time, and they might have different guidelines on what they think their attending should be trained for. But the ED, the ACEP says roughly 150 scans that your provider is efficient and credentialable. Everyone's a little different. We don't use POCUS as much as the adult physicians. So for our fellows, when they graduate and I credential them, their minimum is 50 scans because we just don't use this as much. In the adult population, they use this for everything from gallbladders to aortas to, we don't have a ton of aortic pathology in our patient population. So overall, I think, our standards are a little bit lower just because we don't use it as much. Yeah.
Okay, well, we got to get the residents back to their clinical duties. If anybody who's free can come up and ask more questions.
Thank you, guys.